Hi, everyone. Can you hear me and see me okay? I'm Eveline Stock. I'm a cardiologist here at UCSF, as most of you know me. I'm a preventive cardiologist and a lipidologist, and I am thrilled today to have Dr. Barton Duell and Dr. Gisette Reyes-Soffer here with us in this program where we have invited them to give us a talk about LPA, Lp(a) as it's known, as a risk factor for atherosclerotic cardiovascular disease and the management of elevated LPA. This program came to light as we inaugurated our liposorber treatment here at UCSF. It's an apheresis treatment used to lower ApoB100 containing lipoproteins. That means LDL and all of the bad cholesterol lipoproteins, including Lp(a). This has been mostly used as a last resort type of treatment, and Dr. Soffer will give us a great insights into what these lipoproteins are and why we care. Why do we care about these? So without further ado, Dr. Soffer, please, are you there and ready to get started?
I'm ready. Thank you so much for that introduction. Dr. Stock, it's great to meet you, and it's
All
great
right.
to be here today. Can you hear me fine?
Yes, very
okay. Great. So today my task has been to give you a little background about lipoprotein (a) as a risk factor for atherosclerotic cardiovascular disease. And you heard my name, and I'm at Columbia University Medical Center. And this is a picture of one of our bridges. So I have a little pre-test question for you. So high lipoprotein (a) is a risk factor for A, myocardial infarctions, stroke, PVD, aortic cardiovascular disease, or only A and D, or A, B, C, and D. So all of the above. And so we're going to take a little poll. And I didn't really ask our host how you can answer these, but I think you just press on the best choice. And hopefully some of these polls, I can answer some of those questions for you if you are not sure.
So yes, you can see the button for the poll on the lower right-hand corner of your screen. So if you click where it says more, you can answer the questions.
Great. Thank you so much.
Thank you, everybody.
Great. So as a little background, I always like to have these slides where I speak a little bit about cardiovascular residual risk and why are we here and why do we study lipids and why are we studying lipoproteins. And the reason for that is because this residual risk is mainly due to lipoproteins, but also due to many other things that we don't talk a lot about. So lipoprotein (a) is one of these. And I love this slide, not only because it shows me the residual risk targets that we have pending, but also because it shows me some of the therapies that have been developed in the last couple of years to target some of these. And then also what's coming. So the precision medicine toolbox, where do we need to go? What do we need to pay attention to? And you'll see throughout my presentation that I have provided references for most of the slides and that I've borrowed from publications. And so feel free to copy those references and look into it yourselves. I also like this paper that was published in 2021, where this group studied ApoB and non-HDL cholesterol, and they actually noted that it's better, these are better reflectors of residual risk than LDL cholesterol in patients that are statin treated. And this is really important because this study really wanted to point, if we're treating someone with a statin, which most individuals should be on it, what is the best measure for us to know that they have a remaining cardiovascular risk factor? And I'm focusing on things that are not LPA related right now so that you can later understand what the importance of LPA is. So this is the great figure from their paper that was published in and Jack in 2021. And I like this paper because it shows you on the left-hand side where the lipoproteins are. So what is a chylomicron? What is a very low density lipoprotein? What is an IDL? Where LPA falls into this gamma? And it's a reminder that lipoproteins are merely described based on their components of cholesterol and triglyceride and other proteins that are inside of them. And so their buoyancy describes how they are labeled. So high density, low density. LPA seems to be around the density of an LDL or HDL particle. And the reason we say that is because when we isolate it from plasma, it appears in that density. And we really don't see it in those large VLDL particles, or it's never been really isolated from chylomicrons. And where this paper really highlights is that they really saw that this residual risk was better explained by the non-HDL and the ApoB. So their conclusions were that high ApoB and non-HDL cholesterol were associated with increased risk of all-cause mortality and MI, where no such associations were found for high LDL cholesterol, and that is on statin-treated individuals. So where does LPA come in? This is a slide from the New York Times on the right-hand side in 2018, and this is Bob Harper. He was the celebrity fitness trainer from the TV show The Biggest Loser, and he had a heart attack. He was doing everything he was supposed to do to have heart health, yet he had elevated lipoprotein (a) and had a heart attack. And then that really brought to light a lot of news and enthusiasm around the topic of LPA. But in reality, what has really taken off is patient advocacy. And I say this because we have billing codes right now, or coding billing codes for LPA. And really that was mostly driven by Sandra Tremolis. She started the LPA Foundation, which unfortunately dissolved in 2019. But these two codes here, E7841 for elevated LPA, and then the Z83430 for a family history of LPA, were really driven by patient advocacy and then wanting, for us to be able to diagnose them and screen them for high LPA levels. And the work that she did has really taken off. And now the FH Foundation, or the New Family Heart Foundation, has a really high focus on lipoprotein (a). And I put the website here. They have relevant information, not only for physicians, but also for patients. So it's a really great site if your patient has high LPA and wants to look for resources and information that is easy to read and share with their family members. So what is lipoprotein (a)? So it is an ApoB100 lipoprotein. And I mentioned before that I don't really call it an LDL-like protein because we're not really sure if it's exactly the characteristics of an LDL particle. So we like to call it lipoprotein (a), and that it contains this ApoB100, and then it has a very specific protein that's bound to it, which is ApoA. And this ApoA is what we talk about when we talk about the LPA gene, because that's what it codes for. And this ApoA comes in different sizes. Most individuals have 2 circulating isoforms in their blood, and the sizes of those isoforms are generally different. What we measured and what you get in milligrams per deciliter, there's this big debate about, oh, how can I measure it? Is it mass? Is it the cholesterol that I'm measuring? Is it the triglyceride? And I will tell you the following. Just like an LDL particle, it has cholesterol and triglyceride inside of it. We are not sure if the cholesterol within an LPA particle is a marker of disease, not like the LDL cholesterol that you use. And when you get measurements in milligrams per deciliter, what you're getting is a combination of all the components of the particle. And hence why we say that you should really be getting measurements in nanomoles, because that tells you exactly how much LPA is there and not everything else that is associated with it in another measurement. So as I mentioned before, we have 2 isoforms circulating in your plasma, and these are mostly determined by these Kringle 4 type 2 repeats. And I have here a particle on the left with 18 Kringle 4 type 2 repeats and a particle on the right that has less. So this is the small isoform. And these smaller isoforms are said to be linked to the high levels in plasma. And these larger ones are said to be linked to lower levels. And we think that's because your liver produces a lot more of these smaller lipoproteins. It's able to get out more into the periphery. That's genetically regulated, but we think that may have something to do with the mechanism of where you're producing more of these smaller particles and they're getting out, and hence they're high. So why do we care? So we care because this pathophysiology has shown us that it's not only involved in heart attacks and in stroke, but it also has some links to activation of complement, the inflammatory response, and other coagulation factors. So it's not just one risk factor associated with high levels, it's many risk factors. And so I'll show you this slide again, now in the context of giving you that in addition to other risk factors, residual risk factors that we know, such as lipoproteins, you have LPA, which is the lipoproteins, but it's also an inflammatory marker. It's linked to platelet activation and linked to coagulation. So in 2018, I was part of the NIH NHLBI consensus statement, and this was led by Sam Semikas and a group of other amazing scientists. We met at the NIH and we came up with some ideas of where we thought the field of LPA was going, where it needed to go, and what were the tools that we needed. And this is a great picture just showing on the top panel, and I'm sorry that the resolution is not amazing, but on the top panel, you can see here that LPA really greater than 15 milligrams per deciliter. And at that point, you know, this is all we had. Not a lot of people had nanomoles per liter. I think now in the literature, you'll see more that people are measuring in nanomoles. There is a huge amount of the population that has high LPA levels and that are affected by this. And then on the bottom, we thought you should really understand, so who's at risk, right? So everybody has this high LPA levels. Are they all at risk for cardiovascular disease? So we thought a lot of efforts should be devoted to understanding that better. And then on the bottom, we highlighted that it's not only a particle that is secreted from the liver, but we really don't know how that secretion happens. And we're not really sure how it creates the different disease mechanisms. So how does one LPA come out and cause somebody to have a stroke or an MI or peripheral artery disease? So we're not really sure about that. So we thought efforts should be linked to that, and also to understanding the pathways in the hepatocyte, but also at the artery wall of what the inflammatory pathways were that were regulating its disease-causing mechanisms. And so fast forward a couple of years, and we wrote the American Heart Association scientific statement. And I think this was one of the best efforts that I've ever been involved with because of the breadth of individuals that work together to look into, okay, so it's causing atherosclerosis. Is it really causing atherosclerosis, and what mechanisms? And so from 2018 to 2021, there had not been so much advancement, but we did get a lot more data showing us that it is conclusive, especially the genetic data, that it's one of the top markers for aortic valve disease, that it does cause in some individuals thrombosis. And we still have a lot of work to do, but we now understand also that ethnicity and race are very important when we're looking into LPA and who is at risk. And so this is what we thought we did with this statement. And on the right-hand side, I just show you, what can I take to my patient? So what we thought was that you can definitely measure it. And if it's high, you can provide guidance to patients and family members. You should measure ApoB100 because it's an ApoB100 containing lipoprotein. And if you lower ApoB100, you should be able, some of the medications that lower ApoB100 lower LPA. And in addition to that, you should lower all other risk factors, including ApoB100. And so what can I take to the researcher? We still think that there are a lot more studies that could be done to understand the race ethnicity factors, the genetics. There's many SNPs that have been described, but we really don't know how they affect the disease development, how the disease presents, and then we still don't have conclusive mechanisms of how LPA is actually being synthesized and secreted from the liver. And on that last slide, I forgot to mention, there is a 4-series lecture that was put on by the American Heart Association. And if you really want to know everything about LPA, we had some of the leaders in the field throughout the world put these sections together. And it's a really nice review, and it's free to all American Heart Association members. The next couple of slides, I just want to show you that there is a risk. So high LPA causes an increase in myocardial infarction. The higher your LPA, the higher the risk, and also in ischemic strokes. And the latest data shows, this is all data from ARIC. I'll show you newer data that was published in 2021. But this just shows you that Blacks and whites are at the same risk, and that I have it here circled in red. And anyone greater than 30 milligrams per deciliter is really has almost a 1.5 or 2-fold increase in disease, and these were all significant. This is the latest data, and it came from the UK Biobank, and I thought this was a really nice study, first of all, highlighting that LPA levels are different in different ethnicities, but also highlighting where the risk starts and in whom. And so this really shows, I have another slide coming up where you really show here that the curve for an increased risk starts going up about 30 milligrams or 50 milligrams, not what we thought before that it was greater than 150. And that's actually what the studies that are ongoing for antisense treatments are powered. They are enrolling individuals at that level. So you can see here that we know that they're distributed in this manner, and most cohorts show them distributed in this manner. And on the top panel, I have in this paper those individuals that had absence at enrollment of atherosclerotic cardiovascular disease, and these are individuals that had present atherosclerotic cardiovascular disease. And you can see here that risk is increased in both populations, a lot more in those that had previous disease. And then my last slide on this is really to point out that LPA on its own, independent of LDL cholesterol elevations, is also a risk enhancer of a risk. And so right here is this low LPA with high LDL in green. And you can see that right below it is this high LPA with low LDL cholesterol. And of course, if you have additive effects of high LDL and high LPA. The last slide on this is the frequency of elevated LPA and FH phenotypes. And I wanted to show you this because probably if you're running an apheresis program, these are the type of individuals that you're going to see. And so these are individuals with premature CAD and non-premature CAD. And these are the frequencies of elevated LPA and then adding their FH phenotype. And you can see that 25% in this group with premature CAD, 17% in this group is pretty common. And then in this lighter blue FH plus, elevated LPA group, which is not a mute group, correct? And so some individuals, and I'm sure most of you in the room, if you've been to any European Atherosclerosis Society meeting, are familiar with Dr. Borg Nordesgaard. And he says, when you're with a patient with a certain lipoprotein (a) level, you can say this is like for you and your family having familial FH. So just having a high LPA, independent of what your other lipid levels are, could be considered having FH, and you should pay attention to it. Lastly, to mention that lipoprotein (a) is not only linked to MI and stroke, but it's also the #1 genetic link for aortic stenosis. It's been linked to peripheral arterial disease. And in other conditions, estrogen depletion, FH, as I just mentioned, hypothyroidism, renal insufficiency, as some of the mechanisms of clearance are meant to have been described to be through the kidney. Inflammatory states, and nice to remember that the use of statins can increase LPA levels up to 10 to 12%. That does not mean that people that are at risk for cardiovascular disease should not be on a statin. It just means you have to pay attention to it. So this is my pretest question number 2. What assay should I do to measure LPA? A validated assay, a standardized assay, an assay using monoclonal antibodies, an assay that is isoform independent, only A, B, and D, or all of the above. So we'll give you a couple of minutes. And this has been one of the, while you guys answer this question, this has been one of the challenges of the field. Here we go. Okay. Oh, so this is nice. Not so knowledgeable in this. So one of the challenges that we've had in the field, and I'm sorry because my slides are not advancing right now. Here we go. Okay. So we have no current standardization of the methods used to measure LPA. And the size variability of the particles that I mentioned to you before make it really hard to develop antibodies that are independent of that changes of size and Kringles. And so what do you do when there's no standardized assay and you want to know if your individual has high LPA? So you can use a standardized assay, an isoform that an assay that's independent of the isoforms, an assay that should report in nanomoles. And I told you want to know the number of particles, not how much cholesterol and every other stuff that it has in it. So you want nanomoles per liter. You want the assay to be calibrated and referenced to a standardized material that it's in nanomoles. And you also want the assay should be validated and have acceptable precision limits. So you don't want them to have. And one of the challenges that I hear all the time is that, oh, I had an LPA level and it was 50. And then I went to another lab and it was 500. And so you don't know the units, you don't know anything. So this is what the ideal situation would be, these 1 through 4. And the goal is to ensure common cut points, because right now we don't have a cut point of what is high or what is low, and we can't assess what is the increased risk because everyone's been using all these assays. However, if you do not have this assay, you measure with whatever is available, because independent of what assay you use, if you have high LPA, it will be high no matter which assay you use. However, you're not going to be able to risk stratify populations yet because they're not cohesive assays. But you can counsel your individual with this high LPA on what are the things that we can do at this point in time. In this manuscript that we wrote for the American Heart Association, we also gave you some toolboxes, and I won't go through everything that we gave you, but on the left, you can also calculate, especially if you're going to put a high LPA individual on ApoB lowering treatment or LDL cholesterol lowering treatments, you can calculate how much ApoB is within that LPA particle. And it's an easy calculation. I won't do it for you here, but you can just follow exactly how it is here. We noted it on this statement from the American Heart Association. And in addition to that, this is not perfect, but we did give you sort of an assessment in a primary prevention setting of how to use a 10-year risk estimate with using LPA levels. And so how are we doing at our university with measuring LPA? This is a fellow in my lab, Mariana Paglia, and she's a PGY for UCLA vascular surgery. She's doing a 2-year research at Columbia. And she recently just looked, and this is very preliminary data, but she just looked at who was ordering LPA from 2018 to 22. And you can see here that there's not that many tests, and this is system-wide. So any NYP, New York Presbyterian Hospital system through the track. And you can see here that mostly cardiologists are ordering, which is amazing and great. But you can see here that also other sort of specialties are starting to catch on. We're not really sure why GYN has been measuring it, but that's interesting. But you can also see that if we look at how many tests were ordered and we look at what the guidelines are for risk, using as a risk enhancer, these are not a lot of tests. And so we are still way behind in sort of screening for those individuals that could be at higher risk due to high LPA and high LDL cholesterol. And so I mentioned the issue with cutoffs is really hard when you don't have assays that are validated or standardized across institutions or healthcare systems to come up with a cutoff value or a risk. So most of the risk cutoff values that we use recently are from the Copenhagen General Population Study. We've been using a little bit of the UK Biobank data that I showed you in 2021, that paper that was published. But we also have some multi-ethnic cohorts that have been published in the ATBB, the MESA study, and the InterHeart study. And those have provided some levels. But remember, these studies are old. They're 2015, and I think this one was in 2019. So they're older, so they're measuring in milligrams. So not really what we want to measure. We want nanomoles per liter, and we wanted to have it in large populations so that we can come up with better risk assessment. This is that same paper in 2021, just to let you know that there are papers that have good data and show us that individuals here on the left, I'll show you, I already showed you this data on the left with differences in race. I'm going to show you here that women have a little bit higher levels. Their median was a little bit higher than in men. And then I'm going to show you here this adjusted hazard ratio. And you can see here that the curve really starts to increase right here at 50, but even at 30 is not a flat, and it's starting to increase. So these individuals are really, the high LPA starting to be a risk factor much earlier than what we thought was, much earlier than what we had assumed in previous studies. I'll mention again that you can screen. There's billing codes now that were driven by patients, and that there's various statements now, not only from the American Heart Association, but also from other foundations that pretty much highlight that we should measure LPA at least once in a lifetime. So my first question, I think we had sort of given you the answers at the beginning. You guys were really good in this one. So high lipoprotein levels are risk factor 4, and you were correct. I don't think anyone got this one wrong. A, B, and C, and D. So you can be at risk for MI, stroke, PVD, and aortic cardiovascular disease. And then our second question you weren't so clear about, but this is if you have an assay and you don't have a validated assay, please measure it. But if you know, the ideal setting would be to encourage our healthcare systems to develop a validated assay that standardized, and also that it using monoclonal antibodies that don't use interfere with the isoform sizes. I think I'm done. I think all questions are, we have questions at the end, correct?
Yes, correct. So thank you so much for the wonderful presentation and the clarity of what to measure and when. Luckily at UCSF, I want to let our listeners be rest assured that we have the validated assay. We measure nanomoles per. So we're up to speed with that. So don't worry, you can order it and be rest assured that you have the validated test. We'll have questions at the end, and thank you so much. That was a very, very nice presentation. So now we are going to move on to the next presentation. Can I see the next slide for Dr. Duell?
Let me share the screen here.
Yes, thank you, Dr. Duell. So Dr. Duell is a well-known lipidologist and researcher who has a long track record of studying lipoproteins, and especially now lipoprotein little a. He's a professor of medicine and director of the Lipoprotein LDL Apheresis unit, and director of the sterile analysis laboratory at the Division of Endocrinology at the Oregon Health and Science University in Portland, Oregon. Dr. Duell and I have met many times in the lipid conferences, and we share a common interest in all of these disorders, and also with Dr. Gisette Reyes-Soffer. So welcome, and thank you for your presentation. I'll let you get started.
Great. Thank you very much, Dr. Stock, for your kind introduction and for including me in the program. It's a real honor to be able to participate in this. And thank you also to Dr. Reyes-Soffer for your outstanding lecture, giving a lot of valuable background information on Lp(a). So we'll move forward with this, and there'll be a little bit of repetition, but I wanted to emphasize again that elevated Lp(a) is common, and levels greater than 50, as indicated on this slide, are seen in about 20% of the general population. And there sometimes is debate about who should have an Lp(a) level checked, and my position is everybody really needs to have it done at least once, because 1 in 5 people will have a high level that may put them at risk for cardiovascular disease, which is continuing to be the leading cause of death in the United States and most parts of the world. So you've also heard this as well, that the inheritance, maybe 80 to 90% of inter-individual heterogeneity in Lp(a) levels is related to genetics. So we cannot change our genetics, but other factors can contribute, as you heard from Dr. Reyes-Soffer, including dietary trans fatty acid intake, hypothyroidism, menopause, renal insufficiency, nephrotic syndrome. FH may cause a slight increase in Lp(a). And then statins, not always, but in some cases may increase the level by 11%. And before you panic, if somebody has an Lp(a) level at, let's say, 100 milligrams per deciliter, and it goes up by 10%, it's 110 milligrams per deciliter. So both are in the same range and both have the same clinical implications. And we know that despite this increase, statins unequivocally reduce risk of cardiovascular events. So they are still the mainstay for intervention. Now, the title of my section mentioned guidelines, and unfortunately, we don't really have specific guidelines for Lp(a) management at this point, but this is taken from the 2018 AHA-ACC Multi-Society Guidelines. And what they did is, primarily because we don't have really specific treatments for Lp(a) elevation, they categorized high Lp(a) as a risk-enhancing factor. So kind of like knowing somebody's a smoker, you may not be able to get them to quit, but it means whatever risk they have is accentuated by the presence of that problem. Now, what are the options for managing high Lp(a)? There are no FDA-approved medications for Lp(a) lowering at this point, but there are some exciting drugs in development that I will say a little bit about. Lipoprotein or LDL apheresis is actually FDA approved for Lp(a) lowering, specifically in patients with FH, as I'll show you in a minute. There's no definitive proof that Lp(a) lowering decreases CHD risk, but it's very likely, and there's a lot of indirect evidence to say that it really should be impactful. And then, as you heard in the earlier presentation, having a low LDL cholesterol level doesn't really eliminate the risk attributable to Lp(a), and I'll show you a little bit more in the next couple of slides. So what's shown here is the looking at the odds ratio for high Lp(a) versus low Lp(a) in several, 3 different studies. And this is at the top from the AIM-HIGH study, looking at the placebo group and the niacin group. In the niacin group, the achieved LDL cholesterol concentration was 65 milligrams per deciliter. And in that group, despite having a low LDL cholesterol level, the odds ratio for ASCVD events was still 1.9. For those who had Lp(a) levels over 125 nanomoles per liter, which is crudely roughly equivalent to 50 milligrams per deciliter. In the lipid trial, the achieved LDL cholesterol level was 112, and nobody would argue that that was a sufficient LDL lowering, but in that setting, high Lp(a), in this case greater than 74 milligrams per deciliter, was associated with a significantly increased odds ratio for ASCVD events. And then in the Jupiter trial, the achieved LDL cholesterol level was 55 milligrams per deciliter, and the odds ratio was still high, 1.61 for those with an Lp(a) level greater than 50 nanomoles per liter. So the summary is that Lp(a) attributable risk persists. However, if you push the LDL cholesterol level very low, as in less than 55 milligrams per deciliter, the absolute risk of ASCVD events is very low. And so even if it's bumped up 50% or 100% by the Lp(a), 50% or doubling in a very low risk is still a low number. So still, you should keep aggressively treating high LDL in these patients. And in the near future, we will have specific treatments to allow more effective LPA lowering as well. These are data from the AIM High trial, and I'll show you the statin plus niacin group showing in the red dash line. This is for patients who have the highest Lp(a) levels, and they had the poorest outcome. Event-free survival was down to about 75% in that particular group. So what else can we do? Niacin is an old standby. Many people have thrown niacin away because of recent trials that appeared to show that niacin does not have cardiovascular benefit. But one of the very first trials of cholesterol lowering was the Coronary Drug Project, in which niacin was used as monotherapy in men with coronary artery disease. And it showed unequivocally that niacin reduces the risk of cardiovascular events. So we have solid proof that that's the case. Whether it reduces events in the setting of patients treated with statins or other therapies is really up in the air. But anybody who says niacin does not reduce cardiovascular events is ignoring the Coronary Drug Project trial. So niacin is inexpensive. It may lower Lp(a) levels 20 to 40%. It can have other side effects that I won't go into here for the sake of time, but it's a consideration anyway for some patients with very high Lp(a) levels. Estrogen replacement in postmenopausal women is another very controversial and complicated topic, but if started early, it might have cardiovascular benefit. And it does lower Lp(a) levels by 15 to 20%. Whether that's appropriate or not, I think is a hotly debated issue. Lipoprotein apheresis, that I'll tell you more about in the few slides, acutely lowers Lp(a) levels by 60 to 80%. And as I mentioned earlier, it is FDA approved for Lp(a) lowering in the population of patients with FH. The injectable monoclonal antibodies against PCSK9, alirocumab and evolocumab, lower Lp(a) levels by about 20 to 40%. And there are studies looking at subgroup analyses suggesting that the Lp(a) lowering with these drugs actually does correspond to a reduction in cardiovascular events. Renal transplantation is helpful in patients with renal failure. And then there are exciting experimental therapies coming. This just shows the effects of alirocumab on Lp(a) levels, and works less well in patients who have the highest levels, which is the reverse of what you would like. But in those with Lp(a) levels over 30 milligrams per deciliter, you get a net placebo-corrected reduction of about 25%. And this shows in another way the correlation between the change in Lp(a) levels on the y-axis and LDL cholesterol levels on the x-axis. And as everyone knows, alirocumab and evolocumab produce dramatic drops in LDL cholesterol levels, but although there's a significant correlation between Lp(a) change and LDL cholesterol change, there's a vast difference in the two. And moreover, as I've shown in the box here, there are quite a large number of people who have no change in their Lp(a) level, even in the case of having 80% reductions or more in the LDL cholesterol concentration. Similar data are available for evolocumab, showing at the higher doses, 140 milligrams biweekly, which is a standard dose, or 420 every month. You can get about a 25 to 30% drop in Lp(a). Now, I'd emphasize again, we don't know if that's clinically meaningful, although there are subgroup analyses that suggest that this modest drop in Lp(a) levels did correspond to a reduction in cardiovascular events. So what about LDL and lipoprotein apheresis? This has been around for a long time and has been FDA approved for treatment of patients with FH for about 25 years now. And current FDA indication is for patients who have what they refer to as functional FH, so familial hypercholesterolemia. It doesn't have to be genetically documented, just a clinical diagnosis of FH, and who have CAD or PAD and an LDL cholesterol concentration greater than 100 milligrams per deciliter on maximal therapy. And they threw in LPA greater than 60 milligrams per deciliter. It turns out this really doesn't change the indication significantly, because whether or not patients have high Lp(a), if they meet these other criteria, then they are a potential candidate for treatment with lipoprotein apheresis. If they do have Lp(a) elevation, then they have basically a second indication for it. In the absence of CAD, it's indicated if the LDL cholesterol level is greater than 300 milligrams per deciliter. Based on everything we know at this point, in my opinion, this is kind of an antiquated guideline, because LDL cholesterol levels greater than 300 milligrams on maximal therapy in a patient with FH, particularly homozygous FH, is a potential time bomb and not an acceptable level of LDL cholesterol. And then it's based on a humanitarian use exemption. It's sanctioned by the FDA for treatment of focal segmental glomerulosclerosis. The mechanism by which it works is unclear, but it can induce remission in about 50% of patients with refractory FSGS, topic of another lecture. So it acutely lowers LDL cholesterol levels, 73 to 85%. Treatment typically takes 3 to 4 hours. As I mentioned before, it lowers Lp(a) as well as VLDL and VLDL remnants. Basically, it removes all of the ApoB containing lipoproteins. There's an acute improvement in endothelial function. It also lowers levels of C-reactive protein and oxidized phospholipids. I'll point out that Lp(a) is actually a sink for oxidized phospholipids. So a lot of this reduction in oxidized phospholipids is due to the LPA lowering. We did a study a couple of years ago showing an acute improvement in myocardial microvascular perfusion before and after apheresis. Functional status improves. There's no placebo-controlled trial, but the available data suggests that it may reduce cardiovascular events in FH patients with ASCVD by perhaps about 70% over a decade. There are a lot of techniques for doing lipoprotein apheresis, and the one available in the US is the liposorber system manufactured by Konica. This is based on dextran sulfate absorption. Other systems use different techniques. The HELP system, developed in Germany, involves heparin precipitation of the LDL. There are immunoadsorption techniques, including one I didn't put on the slide that involves adsorption of LPA specifically. And then there's polyacrylamide absorption as well. None of these are really available in the US. In the absence of specific lipoprotein apheresis, semi-selective cascade filtration and non-selective plasmapheresis will eliminate LDL and LPA from plasma, but particularly the latter one is not a great option for long-term treatment because it involves recurrent exposure to blood products. With plasma exchange, basically the patient's plasma is discarded and somebody else's plasma is given to them. So having a specific treatment that's selective, like the dextran sulfate technique, is actually great. Now, there aren't very many centers for lipoprotein apheresis in the US. It's estimated there are 60 centers. Not all of them are active. It's probably 2/3 of them or less are actually actively treating a lot of patients. Total number of patients undergoing apheresis is maybe around 400 at this point, and maybe 3/4 are treated for FH, and then 1/4 are treated for Lp(a) elevation and FSGS. Now, I like showing this slide being on the West Coast because at the center here is our center in Portland, and going north, the next location is 180 miles away in Seattle. Heading south is 600 miles to San Francisco, where Dr. Stock has her apheresis center. I'm sorry, I lost my slides. There we go. And then heading east, the next center is in Salt Lake City, 800 miles away. So if somebody lives up here in Montana, they're going to have a very difficult time finding an apheresis center. This shows a center in North Dakota. I don't think that's active any longer. So there's a lot of wide open space here on the west of the US where apheresis is not accessible. There's no longer apheresis in Alaska as well. And to my knowledge, none in Hawaii. If on the other hand, you live in New York, then you have lots of centers that are available. Okay, so this shows a happy person having their apheresis treatment. This is an old version of the device, but basically venous access is needed. There's an outflow that goes to the machine, and then return blood is run into a different vein. Many patients require a fistula, an arteriovenous fistula, or perhaps having a subdermal port placed, which can be a high flow port. It can be very useful for apheresis. That being said, I have one patient in her 80s who for years and years has been using her native veins for apheresis and continues to successfully do so. I won't get into all of the details of how the procedure works, but basically blood is taken out, run into a plasma separator. The plasma then is run through the liposorber column, which is indicated in the big picture, has cellulose beads that are linked to dextran sulfate, and through charge-charge interactions, ApoB in VLDL, LDL, Lp(a), and remnants binds to the beads. ApoA1 on HDL and ApoA2 pass right through, so HDL cholesterol levels are not significantly affected. The purified blood is then remixed with red blood cells and run back into the body. So it's a continuous recycling here. This shows a schematic of the changes in LDL cholesterol that can be expected over time with diet, intervention, and drug therapy. Patients reach whatever level they can get to. Once apheresis is started, there's an acute drop. And then if the frequency is sufficient to do the next treatment before the patient goes all the way back to baseline, over time, the pre-apheresis level will drop, and then thereby achieving a time average LDL lowering as indicated here. And in patients with homozygous FH, typically we do treatment every week. Those with heterozygous FH typically would be every 2 weeks, but there's a lot of variability there. So in the remaining time, I wanted to go through a clinical case. That's a 52-year-old woman with metabolic syndrome. She had impaired fasting glucose, hypertriglyceridemia, and obesity. Had a family history of late onset stroke in her grandmother. She was obese with a body mass index of 36.6 kilograms per meter squared. Blood pressure was acceptable. She had these lipid profile results, and I saw her initially a long time ago, back in 2005. She had a pretty high LDL cholesterol level, 183 milligrams per deciliter. Triglycerides and HDL were normal. Glucose, high normal. Hemoglobin A1C, mildly elevated. And I put her on treatment with lovastatin, 40 milligrams a day. That gave her these results. LDL down to 112. By today's standards, not good enough, but at the time that was deemed pretty good, and her triglyceride level was mildly elevated. So she came back and had some symptoms of dizziness. I actually heard a carotid bruit on her left. Turns out that she had bilateral severe stenosis. So no bruit on the right because there was not sufficient flow. And MRA imaging showed she had an 80 to 90% stenosis in her left internal carotid artery. So she went from being a routine obese metabolic syndrome patient to having critical carotid artery stenosis. So why did this happen? Well, you've been listening to the lecture on Lp(a), and of course the answer is she had severe Lp(a) elevation. So normal by the milligram per deciliter assay, and I say, quote, normal is up to 30 milligrams per deciliter. And so her level was 8 times the upper limit of normal. So very high Lp(a). She ended up having a left carotid endarterectomy. I put her on niacin, initially 500 milligrams a day and titrated up over time. She made lifestyle changes. We dropped her Lp(a) level by about 25%, which is what you would expect. Got her LDL cholesterol level down to 65, which was a pretty aggressive goal at the time, more than 15 years ago. And so time went on. A year later, she developed left arm numbness. She had worsening right ICA stenosis, up to 80%, greater than 80% stenosis, required a right carotid endarterectomy. So this was a failure. She had bilateral endarterectomies and had untreated, basically, or only partially treated, very high Lp(a) elevation. So that was her primary risk factor as well. And so we ended up initiating lipoprotein apheresis on her. And this shows her levels over time. Started in 2009. This upper line, in case you can't see the scale, is 200 milligrams per deciliter. And the bottom line here is 0. And then the second one is 20 milligrams per deciliter. So you can see there's a lot of variability in her results. But when she was getting treatment frequently, her pre-apheresis concentration was down to around 140, 150, and post-apheresis was dropping down to about 30 milligrams per deciliter. Now, is that good enough? Well, after this is done a number of years ago, but after 12 years of apheresis, she maintained patent carotid arteries. So based on that information, it looks like this has been a very successful treatment for her, and patients quite happy to come in for her every 2 weeks apheresis treatment. And she's also, though, looking forward to experimental or treatment with a drug like pelacarsen that's currently experimental. It's a 3rd generation antisense oligonucleotide that is specific for the messenger RNA for apo(a). It lowers Lp(a) levels in the blood by 80%. And the cardiovascular outcome trial is in progress, which is very important for 2 reasons. One is to prove that Lp(a) lowering actually reduces cardiovascular risk, but also to prove that this drug is worthy of FDA approval. I'll skip over this. Mostly, the drug actually targets the liver, goes into the nucleus, and binds. It's an antisense for the messenger RNA, and does 2 things: blocks transcription and then targets the messenger RNA for degradation by RNase H. I'll have you focus on the left panel here, showing at the dose of 20 milligrams every week over a period of 12 to 16 weeks, the Lp(a) level drops by 80%, and LDL cholesterol levels may go down modestly as well. So the summary, and I'm hurrying a little bit because we started late and I want to have time for questions and answers, but Lp(a) is a very atherogenic lipoprotein that's associated with increased risk of stroke, CAD, peripheral vascular disease, and calcific aortic stenosis. 90% or 80% of inter-individual heterogeneity is due to genetic determinants. So that means if you find a patient with high Lp(a), you should do cascade screening of all first-degree relatives to screen for their very high risk of a high Lp(a). It's unproven if Lp(a) lowering reduces cardiovascular risk, but all of the available evidence says that it is very likely. And within the next 2 years, we should have data from the studies of pelacarsen showing that it will reduce cardiovascular risk. Lipoprotein apheresis is the only FDA-approved treatment for Lp(a) lowering, and only in patients with FH and ASCVD, as I indicated. And then pelacarsen is under development and dramatically lowers Lp(a) levels, as I showed you. There are other agents that are in earlier stages of development. There's a small interfering RNA molecule that reduces Lp(a) levels by 90%. That's an experimental. And then there's a drug obicetrapib, which blocks CETP. It's also in development, and it reduces Lp(a) levels by 50%. So if that makes it to market in many years ahead, that may be another possible agent. So with that, I will finish. Thank you, everyone, for your attention. Thank you, Dr. Stock, for including me in the program. And then important information is on this slide. I will leave this up so you can take it in. I believe you may receive an email with this information as well. If you want to claim CME or MOC credit, you can go to the Opus Medicus website, and you have to fill out an evaluation and do the usual things for that. So thank you again, everyone, for your attention.
Thank you, Dr. Duell. That was an outstanding presentation and gave us a very clear view of Lp(a) and the possibilities and why we should care and what we can do about it. I first want to give a shout out to Dr. Lloyd Damon, who is in the audience for this webinar. He's the director of the Apheresis Center at UCSF, a hematologist who has been substantial, and I credit with the development of our apheresis unit at UCSF. If it wasn't for him, we wouldn't have an apheresis unit. So we had to join forces with the dialysis center, the hematologist, to get this unit up and running, and Dr. Kane and Dr. Malloy from the lipid clinic. So we're very lucky we have this available. And I just enrolled my first new patient. It's been a very gratifying program and a steep learning curve for all of us. And I encourage our clinicians to think about, how they will start using Lp(a) in their practices if they haven't already. Most of our cardiologists know about it. We've disseminated this throughout our university. We have a question from Dr. Carlin Long in the chat that I would like to read out. Carlin Long says he's cardiologist, the director of the Prevention Center at UCSF. He says, yes, PCSK9 can lower LPA and reduce events, but the latter is minimal. Risk reduction is high, relative risk reduction is high, but absolute risk is low. How can we tell patients this really moves the needle for them? Would you like to answer that, Dr. Duell?
Sure, I'll be happy to address that. So what you've stated is absolutely correct, that the effect is pretty small. And I would say treatment with the PCSK9 inhibitor is not a specific treatment for high Lp(a). However, if you're trying to choose between, let's say, bempedoic acid and a PCSK9 inhibitor, and the Lp(a) level is high, then perhaps the PCSK9 inhibitor would, if it's appropriate for the patient based on their LDL cholesterol levels, then I would opt to do that just to give them whatever slight benefit or slight therapeutic edge might come from that.
Okay. And if you have questions, please type them into the chat so we can have Dr. Soffer and Dr. Duell answer them for us. I have a question for Dr. Reyes-Soffer. I know you do have a lot of experience working on mechanisms of disease and lipoprotein clearance and secretion in humans. I wonder, knowing what you know now about Lp(a) and the mechanisms of thrombosis, prothrombosis, and pro-inflammatory, what would be your recommendation for our clinicians when they find a young patient, in their 20s, if they're screening early, how can they approach this patient in a personalized way and say, hey, we should treat your elevated LPA or not with lipid lowering medications?
So, thanks for that question, Eveline. It's really hard because we don't know what is on that particle that's causing disease. And I'll tell you that, Bart mentioned the oxidized phospholipids that we think that are causing most of the disease that's driven through an inflammatory pathway. However, most of the lipid panels don't have oxidized phospholipids on them, right? So you're not getting how much oxidized phospholipids are on them. And the second point is that although there's an assay now, the E06 assay that, Sam and colleagues have developed, we're not really sure because oxidized phospholipids aren't all lipoproteins, right? And there's a lot more LDL than there is LPA. And so in some studies, it's been shown that maybe that has to do with some of the inflammatory profile. The coagulation part is a little bit harder because the coagulation part is for this apo(a), not so much for the B100 part of the particle or the lipid containing part. And so we are not 100% sure of which particles or which type of A is actually linked to coagulation. And in the ongoing studies that are trying to give pelacarsen, they actually haven't found any evidence of thrombosis or any mechanisms. The reason why these pathways have been postulated is that when we isolate LPA, we find all these proteins that are related to coagulation. So I would say for a young individual, and I'll echo some of Bart's comments on LPA lowering, that, I usually, if I'm in the clinic and we're doing a study or something, I usually say, when we lower ApoB, that is atherogenic. We know it goes into the artery wall. LPA is an ApoB containing lipoprotein. If it doesn't have a B, it doesn't come out of the liver. So the lower the B, the less LPA you'll have and the less you'll produce. And so for now, until we can target the A and really lower risk, that's how I explain it. that, we know that this protein is atherogenic and that it's causing disease, and we don't have any other tools but to lower the B. And so the lower you can go with your B and with other risk factors, I think for now, that is the story we have. And I don't think it's probably not a good idea to speak about things that you can't treat or handle. I know that it's really scary. And I think that, if you're going to have a personalized experience, I think you tell them that this protein is even worse. You saw the 3 targets that I show you. It's not just this atherogenic that it goes in the vessel like LDL cholesterol, but I think that's really hard for a patient to understand. It depends on the level of education of that individual. It depends on what relationship you have with them. Some people get anxiety just by not knowing stuff. So you definitely don't want to go down that pathway.
Excellent. And how about treating, people who are middle-aged with an elevated calcium scores? Right now, we're trying to personalize the risk management doing calcium scores as another factor when we sit down with these patients that can help us initiate statin treatments. Do you use that in your practice, and how do you do it?
I'll leave that one to Bart. But I can tell you that for stratification, I think that imaging is amazing, right? Because Bart showed that picture where you have someone on apheresis and you have someone, with apheresis or without apheresis, and you see the huge change. People like pictures, right?
Right.
And I will tell you that one of the things Bart didn't mention is that apheresis takes off ApoB, right? It binds all the ApoB. The drugs that are being developed are ApoA binders.
Right.
So you're not doing anything to the B. So I think people have to be keeping that in mind, that they're not developing an LPA drug. They're developing an A drug, and the B is still going to be there. So.
Right. Yeah, so calcium score imaging is really, to me, amazingly useful because, as you know, Dr. Stock, all the rules are made to be broken. I order calcium score imaging in some patients to reassure them that they're fine. All of their biomarkers are normal. They're physically fit. Their BMI is normal. And yet, to my surprise or alarm, their calcium score comes out very high. So it says that they have something else that's driving their risk. And then it goes the other way. There are patients in whom we think perhaps a disaster is just around the corner, and yet their arteries are like Teflon. And so the doing the calcium score imaging is really like truth serum, right? You find out, you could do a bioassay basically of their arteries to find out what's happening. Now, often it's concordant with what we predict. And if somebody has high Lp(a) and high LDL and a high calcium score, then it's a red alert to say you need to do everything possible to intervene. And at the minimum, aggressive LDL cholesterol lowering is needed. I personally, I put people on aspirin, 81 milligrams a day. There's debate about what level of Lp(a) should be a trigger for that. Some say in milligrams per deciliter over 100. Others say more than 50. I think we don't know well enough at this point, but aspirin helps mitigate some of the thrombotic risk. And then depending on the level of Lp(a), I discuss niacin as a potential option. If it's indicated, PCSK9 inhibitor. And then I reassure them that if they can hold on for a couple of years, then we may have a drug like pelacarsen available that's a very specific treatment. And if it's indicated, LDL lipoprotein apheresis is on the table as well. But as I mentioned, and as you know, that's a very for a very specific population of patients. So do you have a different approach, Dr. Stock? I'd like you to speak up.
Yes, it's so interesting. We've had a couple of cases of very young patients presenting with stroke and elevated LPA. For some reason, stroke has been the presentation in our lipid clinic, and patients. I've always wondered if there is something that is intrinsic to these patients that is having them present with a stroke so early, and mostly carotid vasculature being affected. And then in the older patients, mostly the coronaries and peripheral vascular disease, especially if they're smokers. But do you know of any differential mechanisms in different vascular beds, or it's just too early to tell?
I'll comment. Obviously, Gisette talked about this earlier, but there's something more going on in those patients. So most people with high Lp(a) do not present with a stroke as a teenager or in their 20s. And yet there are those dramatic cases. And in my opinion, there has to be something different. Maybe something about their Lp(a) particles, or perhaps some other factor that is working synergistically. Maybe, they have a mild protein S deficiency or some platelet defect that together with the high Lp(a) causes a problem. But I don't think we have the tools to figure it out at this point.
Yes, some people have advocated for measuring homocysteine levels that seem to remove the A particle from the ApoB100. Gisette, do you have any thoughts about that? Is that something?
No. So the data is very, I saw a paper, I think somebody had mentioned that to me another time, but there's nothing that has come up in any of the large studies where we've sort of come up with a way to ascertain if you're going to have a stroke versus an MI or versus a PAD or aortic valve stenosis. What I can tell you is that sometimes the race has something to do with this. And if you have access to personalized medicine, there are some SNPs that have been described within the Kringle 4 type 2 repeats that predispose people to have different types of diseases. And so I think as we start approaching a more personalized medicine approach, we may be able to identify if there's certain genetic SNPs within the LPA gene that actually make a different particle that's either more prone to cause strokes or anything like that. But I have not seen any data with either homocysteine or even the oxidized phospholipids. We really don't know what is it that they're doing and in which instance should we even measure it, right? Like, are you going to send a panel to measure oxidized phospholipids?
Right. Well, I am very excited about the work you're doing in your lab, and can't wait to hear more about what you find in LPA metabolism. Have you noted many times in my patients, I measure Lp(a) in everybody, and in those with elevated LPA, I tend to follow the levels. Like Bart said, this is not what you're supposed to do, but I'm just curious and follow them a couple of times. And notice that when people are compliant with weight loss, their LPAs tend to go up. Have you noticed that? Or do you have any, thoughts about why this might happen?
No, and actually it's the opposite, where LPA levels seem to go down with the literature on diet is that saturated fatty acids actually decrease LPA levels. And so there's been some randomized diet studies. We're not recommending that people start taking saturated fats to lower their LPA levels. These have been observational studies, but that's been the association. So actually, no, there's been, it may be because you're sort of, you're doing something different with your ApoB, you're making something different and you're lowering other, we don't even know. And this is one of the key things is that we're not even sure if the ApoB that binds to the ApoA in the liver is the same one that's on an LDL particle that's being secreted. So you may have like a different pool of ApoB that's reserved because there's very little LPA compared to ApoB 100, right? You have a ton of ApoB 100 loading triglyceride to make VLDL, right? Because that's what the goal of ApoB is. It's to get loaded up with triglycerides so that your liver doesn't get fatty. And then we have this A in the liver that needs another B. And we don't know if it's that same B that's on that VLDL or if it's a different B that's meant to do something else, right? So I always, I haven't seen any diet studies that have conclusive data that LPA either goes up or down with diet.
No, I agree with that. And I think part of what you're getting at is the claim is made that if you measure Lp(a), it'll be the same every time, and that's just not true. And I have a lot of patients in whom they like to have serial measurements, even though that's discouraged. And with no change in treatment, it bounces around. So it does not go from, let's say, 200 to 50. That does not happen, but it might go to 160 and 200 and 240 in some patients who are variable for unknown reasons. So it might have been coincidence that it went up when they lost weight.
So these assays have a huge CV. So, you have to be really careful with, how you're measuring and when you're measuring it. If it's not the same assay or the same lot, you can get a 15% change depending on the lot number that they're using in the lab to measure these assays. Now, if you have someone where you have a 50 and then you have a 200, like Bart just said, then that's something to be concerned about. But if you have somebody who's 200 and then the next month comes to 220, then that could be inherent assay variability or, something else about yourself during that time. Inflammation, any colds or any inflammatory processes may increase or decrease your LPA level. So that also may be playing a role. One of the things that Bart didn't mention is that you guys have the apheresis program. And, when you do the apheresis, you're also removing CRP and interleukins. And so you're not only decreasing your atherogenic lipoproteins, but you're also decreasing inflammatory markers acutely. You're not removing them forever, but it's very interesting to me if there's a different inflammatory, especially in that patient that Bart showed, they're not having more events because you're removing inflammation every 2 weeks. So they don't have the same pathways.
And that is such an important point to make because we are very interested in this program in our patients who have residual risk. They are on everything they can tolerate and yet keep having events. And so the removal of these cytokines is key to preventing future events. And actually, this first patient that I got involved in the Lipoprotein program is just delighted, despite she had, a bit of a traumatic experience with the catheter placement and all this. She had the apheresis done, and she said she felt better than she has in many years, which you wouldn't expect in somebody on apheresis to say that, but she felt she has an inflammatory disorder, so she could feel the difference. And that's just anecdotal, but I think it is important to consider our patients with residual risk, right?
I think there's another question about niaspan. So Bart, do you want to answer that? If facing insulin resistance for type 2 diabetes, and there is a link between LPA and diabetes, but Bart, you can take that.
Yeah, so I was just noticing that. And the person who asked this is correct, that niacin is effective at inducing insulin resistance. If somebody has robust insulin secretion, then they can take niacin and not have hyperglycemia. However, if somebody's right on the edge, it's possible to convert someone from IGT to overt type 2 diabetes with niacin. So many people avoid niacin for that reason, and especially in patients who have mild hyperglycemia. But that being said, some people take it and don't have a significant worsening of their hyperglycemia. So you should absolutely monitor glucose levels in patients in whom you treat with niacin. And there's a long list of other side effects. You can activate peptic ulcer disease, uric acid goes up, you can cause gout, and obviously itching, flushing can be side effects as well. So, but there are patients who do really well with it and like taking it.
Excellent. Well, I want to thank you both for your kind and very informative and excellent presentations. This has been a treat, truly, and I am so glad we had the opportunity to have you both here. And please come visit, come see us, and we would love to have you again. And I believe this presentations have been recorded, and hopefully they'll be available to our attendees. I will post, email me if you would like to have access, and I'll make sure that you get a copy of the video.